Dear colleagues, my name is Gyula Szőcs. I would like to share my 12 months progress report with you. My research topic is investigating the safety and efficacy of surgical and conservative knee cartilage preserving techniques. About myself, I work as a resident at the Department of Orthopaedics and Traumatology at Uzsoki Hospital. My supervisor is Hangodi György Márk, and my SMS is Váncsa Szilárd. Our vision is to decrease the number of total knee arthroplasties in Hungary, and we would like to achieve that by increasing the use of knee cartilage preserving practices. We have two ongoing projects regarding knee cartilage preserving techniques. First project started in September of last year. It's about comparing the safety and efficacy of two surgical interventions, meniscal repair or meniscectomy during anterior cruciate ligament reconstruction. But the background, ACL is a tendon ligament which connects the femur to the tibia and provides anteroposterior and rotational stability inside the knee joint. There are around 200,000 ACL ruptures per year in the United States, and from this number, around 100,000 is reconstructed. This number is around 3,500 in Hungary. During an ACL rupture, there is a possibility of other damages inside the knee. So 55% of the cases, there is a lateral meniscal tear, and 45% of the cases, there is a medial meniscal tear. The menisci inside the knee joint are a C-shaped fibrocartilage, and they increase stability and distribute load. When we are talking about torn meniscus, there are two major operative treatments for it. One is a meniscectomy, which is removing the damaged part, but it can lead to instability. The other surgical option is meniscus repair, which is basically suturing the meniscus and retaining it. It has been shown that preserving or repairing the meniscus can prevent early onset osteoarthritis. But still, in 94% of the cases, there is a meniscectomy performed, and only around in 6% of the cases, there is a suture. There can be a lot of reasons for it. For example, select population can be sutured depending on the localization of the rupture. Also, it is considered to have a longer surgical time and the most difficult technique, and also it's more costly. So our aim was to compare these two surgical interventions. Inside the PICO framework, our population was patients with concomitant ACL and meniscus tear, comparing the two interventions. Our main outcomes, what we were looking for, are scores, clinical scores, patient-reported scores, also some radiological outcome and failure rates. Okay, so we conducted our systematic research in October of last year. We had more than 10,000 articles. We managed to have 25 what we could include. Our first result is the RISHOM score. So it's a patient-reported outcome. It's a subjective outcome. It is widely used for assessing knee injuries. It contains 8 items, and it has a score system between 0 and 100. As you can see in the first plot, we included 3 studies, 2 of which we could separate lateral and medial meniscus injuries. And in this first plot, you can see that we compared the preoperative to postoperative changes between the two interventions. And we had, as you can see, minus 2.6 change, which difference between the changes. It means that there was 2.6 point from a 100-point score system, so it's not a significant difference, neither statistically or clinically. Our next outcome was the Q score. It's knee injury and osteoarthritis outcome score. It's just as before, it's a 100-point score system. It has 5 subgroups. If you look at the outcomes, in one of the 5 subgroups, there is a statistical significant difference, but it's not a clinically significant difference. We separated the medial and lateral meniscus injuries in Q score, but we found the same, so neither in the medial neither in the lateral meniscus injuries there were no significant differences between the two interventions. Our next outcome score is the IKDC score. Just as before, it's a patient-reported outcome between 0 and 100. We also couldn't find any significant difference with this score system, but you can see it a little bit favors the repair. Our last outcome that we could analyze was the KT arthrometer. It's a device that examines the anterior translation of the tibia relative to the femur. It gives the outcome in millimeters, so the difference was 0.5 millimeter between the two interventions, so it's also not a significant outcome. Okay, the strengths and summary of the meta-analysis. Luckily, we could include much more articles than before, and we could do much more meta-analysis than before. We could also separate the lateral and meniscal injuries. The biggest limitation that I would say is that there were no RCTs available, and we could basically only include retrospective studies. As I already mentioned, depending on the type and the localization of the tears, not every tear can be repaired. Inside the studies, the time to surgery was heterogenic. Also, the follow-up time was heterogenic. It was around 1 and 2 years. And obviously, there were differences in ACL reconstruction techniques. So our main conclusion is that based on our results, we didn't find any significant difference in the efficacy of either surgical intervention. This means that both of the interventions had the same result, but in both of the cases, it meant a much better result than before the surgery. Our implication for practice is, if we consider this 2 years follow-up, meniscectomy can be just as effective and meniscus repair. And the implication for research is that we should have different types of studies depending on the site and the localization of the rupture. Obviously, there should be some RCTs, and there should be different follow-up times. We believe that the repair's advantage would be seen at 5 or 10 years outcome, much more than in the short-term outcomes. Also, there should be separation of the age groups. This is our manuscript status right now. We are about to finish the article, and it's about to send to internal review. Our next topic and study is about intra-articular injections treating the knee osteoarthritis. It started in November last year. A little bit about background. Obviously, osteoarthritis is a degenerative joint disease, and that results from breakdown of joint cartilage and underlying bone. The most common symptoms are commonly known: joint pain, swelling, and decreased range of motion. Osteoarthritis is affecting around 30 million people in the United States alone, and globally it is believed that about 80% of all osteoarthritic cases is related to the knee joint. About the treatment of it, 2 major treatments. Obviously, is conservative or surgical treatment. Surgical is mainly total knee arthroplasties, and from the conservative side, the intra-articular injection is the central and most commonly used. It presents a low risk of harm while providing short-term pain reduction and also improved joint function. We could include the most famously known injections like corticosteroids, platelet-rich plasma, hyaluronic acid, and many more. But despite having so much options, there is no clear recommendation or consensus which one to use it. But recent studies shows great success when combining hyaluronic acid with PRP. So this why our aim was to compare these different intra-articular options. You can see our PICO framework here. And we believe, our hypothesis is that if we combine hyaluronic acid with PRP, we are going to have a superior result than other injections. And obviously, our clinical implication is that if we can improve pain and function in knee osteoarthritis, we can decrease the number of total knee arthroplasties. We conducted our systematic search, and we have started our selection process. We are at the abstract and title phase right now. So this is our 2 ongoing projects right now. And I would like to finish with a quote: "To infinity and beyond."
Just one question to you, Gyula. You were talking about the 1 or 2 year follow-up results, but we all know that the cartilage degeneration can appear a little bit later. So if, for instance, we compare the results of microfracture or mosaic-plasty, that can be seen that up to 2 years they produce the same results, and then the results are different. So taking into consideration this fact, do you think you should follow, or you should search the literature with a longer follow-up? I mean, 4 or 5 years? Because I suppose that 1 or 2 year follow-up can be a little bit short.
Yeah. So we researched every articles. We didn't have an age restriction of the follow-up, so we wanted to get all the studies. But like at 5 years and 10 years, we could only find a few studies from which we couldn't do a meta-analysis, unfortunately.
Congrats, Gyula, fantastic. Actually, I was just wondering, is it really so hard to perform a randomized clinical trial in this topic?
I think
or it isn't so important to perform one?
I think the most important problem with the randomized trials in this case that usually you have an MRI, which on that one you can see if there is a rupture or no rupture, but its sensitivity and specificity is not 100%. So in a number of cases, to have a meniscal repair or not is an intraoperative decision. So that obviously causes it that you can't blind it and it can be randomized. But yeah, sure, it would be very important to have at least one in the topic.